welcome guys. Let's get going and let's talk a little bit about capnography. So here's our objectives today. We're gonna talk about understanding why we use capnography. We're gonna talk a little bit about the physiology of respiration and ventilation, and we're gonna understand the four major applications of EtCO2 and define their normal and abnormal values. And so let's first talk about why we use capnography. So first off, it's in our protocols, but I don't want you guys just doing things because you're told to. We're not monkeys. So let's read our patients. Let's read our monitors. Let's learn how to use our tools so that we can better treat our patients and be better EMTs. So one of the biggest reasons why we use capnography is tube placement. This is the gold standard. That's the slide. So no waveform, no tube, as it says. There's lots of different, when I was going through EMT intermediate, we learned all sorts of different place verifications, methods like the esophageal detector devices, missing the tubes, the BAM devices, are all sorts of different things, but this is the gold standard. So visualizing it go through the vocal cords, lung sounds, and EtCO2 is really it. So respiration, ventilation, oxygenation. So capnography assesses ventilation, which essentially, obviously it's different from oxygenation, but ventilation is the air movement in and out of the lungs, while oxygenation is the amount of oxygen inhaled by the lungs that reaches the bloodstream. We use pulse oximetry to assess our oxygenation, and now we have EtCO2 to assess our output of our carbon dioxide. Just like an EKG, capnography has a waveform that allows us to see, at least in part, what's going on with the patient's ventilatory status. In people with healthy lungs, the brain responds to changes in CO2 levels in the bloodstream to control ventilation. We assess this by observing chest rise and fall, assessing respiratory effort, count respiratory rate, and listening to breath sounds. EtCO2 adds an objective measurement to these findings. The patient's respiratory rate should increase as CO2 rises and decrease as CO2 falls. Here's just a little physiology, how the whole thing works. We're just going to kind of get through this. Here's some factors that next slide, maybe.
Sorry, it's clicking
Oh
through
yeah, it's going through all that. We're not going to spend a lot of time on this one. We're got a limited time here. So factors that affect our CO2 levels going to be your muscular activity, your cardiac output, bronchospasms, hypo and hyperventilations, and just the opposite with your decreasing EtCO2. So let's talk about what a normal EtCO2 is and what it looks like. First though, let's talk about a capnogram. Capnogram is a real-time waveform record of the concentration of carbon dioxide in the respiratory gases. And a capnograph is that waveform plus a numerical value. Our normal range is 35 to 45 for CO2, and we're going to talk about what happens when we go below and above that. So back to the normal waveform. So click through all those.
Okay.
I didn't know it actually did. So keep going, keep going, keep going. Okay, so our A, our flat part is represents the end of our inspiration, and our B is the beginning of our exhalation. So as we start exhaling, we're breathing off our CO2, and so that's why it's a nice long spike. So at C is when we kind of plateau our exhalation and our CO2 is going along, and D represents the end of our exhalation and the beginning of a new breath. So as we breathe in, obviously there's no CO coming out, so that's why it drops back down to our baseline. Notice how they're pretty close to straight up and down. We're going to talk about different waveforms and what they mean for us. So this is just a nice normal, we're in our range of 35 to 45. We got our normal respirations, which, 12 to 20, we know that's normal. So just nice, nice looking boxes there. So this is our normal capnography waveform. So when someone is hypoventilating, you can now see that because they're not breathing as fast, they're not able to exhale or get rid of the CO2. So they're starting to get CO2 buildup. So their CO2 number is going up. Their respirations have gone down, and you can see that they're just taking that lot longer time to try and get off what they have. So overall, it's just going to be a nice lot longer of a breath versus someone that's hyperventilating. They're breathing off too much, so now you see that our number's lower than our 35, and our respirations have gone way up. Does that make sense to everyone?
Yeah.
That's cool. So this is a useful tool to identify when patients have an altered mental status, when they need assisted ventilations with a bag valve mask. When the brain does not respond appropriately to CO2, such as an overdose, head injury, or seizure, excess CO2 accumulates in the lungs through the EtCO2 reading, may be high or low because of this. Perfect. So we are going to use capnography for four main reasons. So for asthmatics, monitoring head injuries, cardiac arrest, and tube conformation. So we have two different measuring devices. This one is just like a nasal cannula that hooks up the same way as a nasal cannula. We can actually use it to flow oxygen to, and it still gives us our reading. And this one is a direct hook that goes in between our ET tube and our bag valve mask. And we have pediatrics and adult versions of these. So now let's get into our asthmatics. So with patients with asthma, COPD, CHF, pneumonia, they often exert themselves to exhale with accessory muscles. So when they start exhaling, it's more of a, you're not getting that sharp incline because they're not able to breathe that off because they've got these respiratory problems, which causes that shark fin shape. In this group of patients, means that their effort is not effectively eliminating the CO2, and EtCO2 may rise or fall depending on tidal volume. In cases of bronchospasm, air is trapped in the alveoli and inconsistently releases that CO2. This creates a curve in the initial spike and a plateau or shark fin appearance. The worse the bronchial constriction, the more pronounced the curve on the waveform. If the waveform is upright and crisp, there is no bronchospasm, and respiratory distress must be from a different cause. We got three different kind of levels here to show you, mild, moderate versus severe. Mild, you can see, is just it's shorter. The respirations are still fast, but their EtCO2 isn't too far off, but it is below our 35. Versus a moderate attack, you start seeing it's getting longer and longer. The respirations have gone down. Versus, let's go to the next slide, and you'll see severe. So if you see this on your monitor, you know that this person's in trouble. You know this person is on their way to respiratory failure. You can see that they're not able to get the CO2 off because they're above the 45, and obviously the respirations are going to be lower on this. All right, so our patients with our head injuries. So carbon dioxide dilates our cerebral blood vessels. With that, it increases the blood volume in our intracranial vault, and thereby it increases intracranial pressure, which people with head injuries, we don't want to increase the ICP. So On head injuries, we're gonna try and target our CO2 levels between 30 and 35, thereby trying to decrease ICP. We're not necessarily hyperventilating them. Intubating a head injury patient and using capnography gives a means to closely monitor CO2 levels. So essentially we're titrating, not really hyperventilating. Then let's move to cardiac arrest. So we talked a little bit about this at the beginning, that this is just in cardiac arrest, our tube placement. This is our gold standard, and capnography is in an intubated cardiac arrest patient is a direct correlation to cardiac output. Increase in CO2 during CPR can be an early indicator of ROSC. So if we're going and we see a spike in our CO2, we should suspect ROSC. There's good numbers on the termination of resuscitation. So non-survivors, you're going to see it at less than 10, and survivors, you're going to see it at greater than 30. Okay, so we're going to go into just a quick quiz. I'm not going to bore you on this on the video with this, but we're going to just go through a quick quiz, and we're going to actually get out on a monitor and plug it in, play with it, hook it up, and we're going to have one of our guys actually hyperventilate so we can see those numbers go down, and someone really hold their breath and try and get those numbers to go up. So we're going to play with this, but we're going to do it off video. Thanks.
Thanks, Pete.